All right, I wanted to hop on here today and do a research article review. First of all, talk a little bit about the process, which there is a separate video breaking down my research process that goes over that, but it has changed a little bit. I still have crawlers that come through on a variety of topics. Those, just a quick summary of that previous video, when those articles come through my mailbox, I skim them real quick, I open up all the tabs, I kind of then read the abstract, anything that looks promising. I have a couple different research folders within Evernote. I just use Evernote because of the plugin with Chrome, and then send those over to a folder in Evernote in full article format. So if I'm, let's say, traveling or something like that, I can just pull up my phone. The article is already in Evernote. I don't have to download it, which is pretty nice. So I do that, and then I'll read it, and then I may bank it in a long-term folder. Sometimes I still go hard copy when it's something like this. This is just something that I thought that we should look into a little bit more, and I say we, Seth and I, Seth Graham, are not revamping, but really honing the art of assessment. As we do that, we're trying to make sure that we're covering our basis on the fundamental things. One of those fundamental things, it is our trigger points. So this is a lit review that was done by Shaw et al. In 2015, and basically it says, I'll just read the first sentence here. It says, the intent of this paper to discuss the evolving role of myofascial trigger points in the myofascial pain syndrome from both a historical and scientific perspective. You can see I've got a lot of tabs on here. I'm going to hit the high points and then go from there, and we'll just kind of see what comes of it. If you have questions on this in particular, and again, this is only for residency members, so this isn't going to be out, for Gen Pop. If you have questions on this, just, put them in the Facebook group. You can comment below, because this is a blog post, so just let me know, or you can just send an email. So first thing that we want to look at, I think we all know the definition of a trigger point for sure. What I didn't know is that trigger points were first identified as clinically significant and all the way back from basically in the 1500s. Guillaume de Ballou of France was one of the first to write in detail about muscle pain disorders, and then in 1816, a British physician, Balfour, associated thickenings or nodular tumors in muscle with local regional pain syndrome. Which leads me to one constant theme is, why is this discussed as if trigger points may not exist or might? I think the might comes down to that the only thing that we still can use as a reliable test is palpation. You have seen new things. If you've seen this PACT sensor that is supposedly looking at thickenings in the underlying tissues, what's that backed up against? Ultrasound and then palpation. So palpation makes it maybe way more subjective than some would like. Moving on, let's go to the next tab here. Just something that I think is of note. Latent trigger points show physical characteristics as the same physical characteristics as active trigger points, but are painful only when palpated. That's important to know because active trigger point can be causing the primary symptoms that somebody comes in your office with. It does not mean that secondary or latent trigger points, and then you can have satellite trigger points that are trigger points that surround either primary or an active or secondary or latent, trigger point. But the fact that we would still need to treat those latent trigger points is probably of clinical significance and very important to most cases that we're going to deal with, which we'll talk about the treatment strategy around these things as they propose it. So why do trigger points exist if they are a real thing, which I think all of us on this video would agree? One of the first and most appreciated hypothesis is called the Cinderella hypothesis. The Cinderella hypothesis was according to Henneman, and I'll just kind of read what his thoughts on this. It basically describes how musculoskeletal disorder symptoms may arise from muscle recruitment patterns during submaximal level exertions with moderate or low physical load. So you can kind of get this a couple ways. One way would be you're doing the same thing. So think of this was the assembly line worker theory, that you do the same thing repetitively. It's not traumatic in itself, but it's a sub-threshold movement, sub-threshold being both pain and injury. You could also get it from what? Sub-threshold compensatory movements, because now we have to think about, well, is a muscle not intended to do the same thing over and over ad nauseum for the rest of your life? I think that also is going to be dependent on somebody's physiology, psychological state. There's a lot of things to that. But subthreshold is, not minimal enough work to not create damage over time. And that's the other thing to appreciate here is that it is work. We're just not registering subthreshold as painful. And then we could also get this from, athletic performance, that we're doing the same thing over and over again, maybe not with aberrant mechanics, but it's still enough to create an issue down the line. According to Henneman's size principle, smaller type 1 muscle fibers are recruited first and de-recruited last during static muscle exertions. As a result, these Cinderella fibers are continuously activated and metabolically overloaded. Basically, Cinderella gets all the work that her ugly, stepsisters don't want to do. In contrast to larger motor muscle fibers that do not work as hard and spend less time being active. In essence, saying that slow twitch muscle fibers, which are oxidative, also proprioceptive, which may then lead to, if these fibers get inundated with activity, that they will change. We'll listen here pretty soon about how they change input into the dorsal horn, which then changes what comes out of the ventral horn. But also you have less ability to compete with nociception when proprioceptors are being sucked up with a workload. So there's also that kind of thought process going in here. Moving on. We also know that from a classic definition that local twitch response is part of something of an active trigger point. Even though that is part of the definition of an active trigger point, according to this paper, the review, the latent twitch response, LTR, is not yet fully understood, though this response may be due to altered sensory spinal processing resulting from sensitized peripheral mechanical nociceptors, which gets into, which I was really happy to see, they talk a lot about central sensitization, the theories behind why that occurs, and how trigger points are tied into that. One of the big things that I highlighted here when it's talking about the local twitch response and why it may occur, it says originally attributed to dysfunctional muscle spindles, the excess electrical activity was later identified as an increase in miniature end plate potentials and excessive acetylcholine release. Why do I put that in there? Because in our day and age, in particular the over-caffeinated day and age, acetylcholine receptors are already being competed with enough, and then if we put somebody under undue stress, maybe their diet doesn't uphold healthy physiology, and then we give them subthreshold workload, perfect storm for some trigger points to show up and whatever you want to call that, musculoskeletal pain, myofascial pain syndrome, blah, blah, blah. Moving on, now here's a little bit, let me read it real quick. So muscular trigger points, the primary system, myofascial pain syndrome, detraction from the possibility, blah, blah, blah. Quinter and Cohen hypothesized that a more likely explanation for the cause of myofascial pain syndrome involves sensitization of the nervi nivorum. And we know the nervi nivorum are basically the innervation of the neural sheath. So they're saying that these micro neurologic structures are getting sensitized peripherally, and then that leads to eliciting more pain. But then the thought process here is, well, is the trigger point the actual pain generator, or is it the nociceptive fibers that are around or surrounding that trigger point? Moving down, now we're looking at ultrasound of trigger points, and it's a study by Sikdar. This study demonstrated that muscular trigger points have diminished vibration amplitude on external vibration that is consistent with local regions of increased mechanical stiffness. If you've heard Thomas Schode talk, he talks a lot about how local vibration, not whole body vibration, can be potent for getting appropriate muscular relaxation all the way to, he can induce, I don't know what you call it, it's not partial paralysis, but inability to use somebody's gastric soleus group by placing vibration on certain spots on the lower shank. Now we get into the next part of this article is the role of pain, peripheral and central sensitization. And sorry, there's going to be a lot of reading here. So this says, stimulated by Simon's work, Shaw et al. Hypothesized that local tissue injury with concomitant elevation of various inflammatory mediators such as catecholamines, neurogenic peptides, and cytokines leads to sensitization of the nociceptor terminal, peripheral, i.e. peripheral sensitization. In addition, small fiber unmyelinated afferents have been found to exhibit retrograde neurosecretory properties similar to sympathetic fibers, involving a process known as neurogenic inflammation. If you heard Alex talking on our last show about his swollen weenus, as funny as that sounds, that the skin, the actual skin, right, of his elbow over his olecranon was what was sensitive and painful. And then he had a trigger point in the lateral head of his tricep that wasn't necessarily referring, so we may call that a latent trigger point. But they're saying here that this subthreshold, like when you stir up a trigger point, you start changing the chemical cascade into the nociceptor terminal, that then creates this process of peripheral sensitization that we'll call neurogenic inflammation. Talk about this all the time of, the possibility can neurogenic inflammation persist beyond some of the typical pathologies and maladies that we're seeing. So say somebody has a herniated disc, they have some sort of nerve effacement, we're having legitimate radicular symptoms, well, then we know that nerve swells. Well, when that nerve swells, pain changes movement. It would be a very high correlation of having some sort of compensatory movement, throw down some trigger points from a neurologically or centrally mediated standpoint. And now we have a nerve that was irritated that may not move through the myofascial network quite as well. And then the local tissues themselves are having a cascade into the dorsal horn. And now we really have to be aware of what is creating the pain. Let's say if somebody comes in 3 weeks post initial incident, 3 months, right, versus first day, they come in, hobbled, antalgic, all these things. So I'm just always curious about, what's creating the pain? Because we were talking the other day in the office about, which this will be a future video, of osteoarthritis and how that's mainly an immune-regulated pain response. Moving on. The continual bombardment of primary afferent activity over time can lead to abnormal function and structural changes in the dorsal root ganglia and dorsal horn neurons. So again, here is central sensitization coming into play. This is known as central sensitization. Now, it goes on to explain a biochemical cascade to this. I'm not going to bore you with all the cyclooxygenase 2 and all the things that are going on, but it's not just the mechanical, it's the chemical cascade that occurs. I think we know that if you have a disc herniation, there's a mechanical effacement. There's also a chemical milieu, from interdiscal material. Then the inflammatory cascade that's going to be sent there, that's mediated by the immune system. Moving on. This says, Needham et al. Demonstrated increased limbic system, i.e. anterior insula activity in patients with upper trapezius myofascial pain syndrome. So they have a whole section here on the limbic system and how often it was implicated in myofascial pain syndrome. And maybe I was making it up, but I thought there was a stat on exactly how much increased activity in the limbic system. I thought I gave a percentage, maybe not, but demonstrated an increased limbic. So that something that was statistically significant that they found. I think we would all know that, but then when we take it, myofascial pain syndrome, further out towards something like, if we want to label it fibromyalgia, multifocal pain syndrome, whatever it is, then we have to start thinking about, more of that chronic pain scenario, yellow flag questionnaire. What's this person dealing with that may have, maybe we had an initial injury and an initial thing. And I always think of even though fibromyalgia maybe has its own milieu, but when we see chronic pain, widespread chronic pain, if that's what we want to call myofascial pain syndrome, almost just like a systemic, reflex sympathetic dystrophy. So instead of this local response, like we've done a case in the past with a patient that dropped a water bottle, or I think her kid dropped a water bottle on her foot and had legit CRIPS, chronic regional pain syndrome, whatever you want to call it. That's kind of what you're getting now. Do you get this massive inflammatory cascade, swelling, redness, heat? No, but it's kind of what's going on. It's just at a much lower level, because now we have to start thinking, well, is it immune regulated? Is there limbic system involvement? Yeah. What is the actual, trigger down the line in terms of, is it the nevi nevorum? Is it the dorsal root sensitization? Is it the actual trigger point? Is blah, blah, we're always curious. Maybe we can't exactly put our finger on what is creating the pain or causing the pain. Do we need to be that worried about it or not? You always want to think about it, because that's what makes you better, is kind of digging into these things. Now this part of the article says sensitization without pain. It says these latent trigger points send nociceptive, subthreshold signals to the dorsal horn of the spinal cord. This would effectively sensitize the central nervous system without the perception of pain. So that's that subthreshold input. Second, ineffective synapses exist within the dorsal horn. In this way, nociceptors from muscle containing the muscular trigger points have connections to dorsal horn neurons innervating remote muscle regions, which is their theory on why you have specific and remote referral sites for trigger points that were obviously cataloged by Simons and Travell. that's one of the theories. It does make sense that if you kind of, peg into the dorsal horn, and then you have these, these cascading, cascade of chemicals that changes over time. Now the thing is, why is that map the same for everybody? Why are these, why are some muscles so, why do you have a soleus trigger point that refers into the SI joint, and it only refers into the SI joint? It's not like a radicular pattern. Why are some muscles, like the anterior middle scalene, have such a diffuse referral pattern, whereas the upper trapezius really doesn't? Like, it's not size dependent. And maybe there is an embryologic input here that, different germ layers that, things are coming from in the musculoskeletal system or myofascial system is coming all from the same germ layer. You're going to have slight changes based on compartments. But yeah, that's a discussion for another time and place. But theories on why they refer. This one gets into the evolving concept of pain perception. This just basically says that, in particular, more recent findings and data suggest that other processes such as neurogenic inflammation, sensitization of wide dynamic range neurons, and limbic system dysfunction may play a role in the initiation, amplification, or perpetuation of MPS, myofascial pain syndrome. So what's that mean? Neurogenic inflammation. Consistent prolonged trigger point formation that is now creating a peripheral and then central sensitization process. And then that's what they're saying by, okay, now we're sensitizing these WDRs at the dorsal horn. And then we get this not only central, like spinal cord sensitization, we get this chronic pain central sensitization, causing a top-down cascade that maybe isn't physiologic, or it is physiologic, but it's mediated now maybe by a psychologic response. And we put all those three together, and what's that sound like? That sounds like a chronic pain scenario. Now, picking your entry point on which one you go after gets down to what? Well, clinical prowess, history assessment, questionnaires, if that's your jam, things like that. Keep rolling through. Now it gets into treatment. This is just something that I didn't realize, and I feel like an idiot. I guess I should have known this. It says in a study of 241 chronic myofascial patients with various pain sites, Levitt found that dry needling caused immediate analgesia in 87% of cases. It's not that I didn't know dry needling was effective. I didn't realize Levitt was the first one to differentiate between basically saline and lidocaine injections and pure dry needling using still a hypodermic needle, which was extremely painful. And it says that currently clinicians use acupuncture needles to minimize pain and tissue injury, and have found that inserting a needle into the general area of the muscular trigger point as opposed to inserting a needle into the general area of the muscular trigger point as opposed to directly into the muscular trigger point can have the same therapeutic effect, which is kind of interesting because we, maybe you're taught to kind of find the palpable, taut band or nodule with a twitch response and go right in after it. This is saying around, which if you're familiar with like Callison's motor index points, that's kind of what he's working around, is using acupuncture points around the trigger point to then go after maybe an improved response with less pain. And then that gets into this last little piece that we're going to talk about, where Melzack and Wall found that acupuncture points for pain and muscular trigger point sites share a close spatial relationship, 71% overall correspondence. And we all know that there are acupuncture points called Ashi points, which are pain points, but then they're saying legitimate acupuncture points on meridians have overlap of 71%. Now, I haven't finished it completely because the website's been down, but Stecco's online education has a course, which I'm 4 videos in, that has the overlap of Stecco, which Stecco has a plethora of points on its own, and acupuncture, which is another interesting thought that I've always had of these crossover points. We talk about this in the art of assessment, that you have acupuncture points, reflex stimulation points, Marma points, Ayurvedic points, it goes on and on. If I had to learn, a point system that I think is going to cover more important areas that I'm going to work with, maybe without a needle, it's going to be reflex stimulation points, because you see those same points persist throughout almost all of these these mapped out systems. And then next would be probably for me acupuncture points, and that's why I use literally the iPad app of Callison's motor index points to match like around trigger points. Okay, what acupuncture points would I use? I use very little traditional acupuncture in my practice outside of some headache protocols, sinus protocols, And then I play around with certain acupuncture points in the lower extremity, if it's an ankle sprain or something like that. But very interesting when you see these crossovers. If I had a professional animator or designer on, our media team or something, I would have somebody just overlay all of those points and create a cool animation. So if somebody wants to do that, that would be awesome. Tell me how much you want to charge me for that, because I'll pay for it. And then as we get into kind of the summary here, it says when we're looking at treatment, and this kind of makes sense, but it's good to see this from an evidence perspective of what's needed, and then we know it. Okay, we're backing ourselves up. We're evidence-based now. But during the pain control phase, trigger points are deactivated, which they're saying are deactivated. So nervous system downregulation, improving circulation. So we know that just like an adjustment. So if we do, this is the question that we're trying to get to here. Should we focus on trigger point treatment, or in a systems approach, should we focus on joint restriction? Should we focus on the limbic system involvement? Well, we see improved circulation, which we'll also get with an adjustment, decreasing pathologic nociceptive activity, decreased pain, and eliminating the abnormal biomechanical force patterns. So as you decrease tension, you offload maybe, let's say, a joint. So if any muscle that crosses a joint creates compression, a muscle that's on chronic strain or load is going to create chronic compression. During the deep conditioning phase, so this is like the second phase, so let's say this is moving from table work to more active care, the intra and inter-tissue mobility of the functional unit is improved, which may include specific muscle stretches, neurodynamic mobilizations, joint mobilizations, orthotics, and strengthening muscles. So what are they saying? Yeah, do your passive stuff, back it up with active. And this is a giant article that is 17 pages long, and then has another almost 15 to 20 pages of references with some old school drawings and charts in the back, which I do not think are that helpful. It does give a cool little chart that basically breaks down, which I might throw this into the art of assessment. I'll put this in there. That breaks down what a trigger point is, what to look for, treatment approaches. Some of this is pretty old. We're not doing spray and stretch for myofascial pain syndrome or trigger points. But these, I would call this a keystone article, right? We have keystone articles around chiropractic adjusting, trigger points. I think these are articles that you need to have. You need to own this information. Again, this doesn't really give us a whole lot of, we know what a trigger point is. We know maybe why pain is being caused around those, both local and referred, how they may play into peripheral and central sensitization. I think we had a pretty good idea how to treat it. This is backed up in here. And then also understanding how important that is to maybe, long-lasting chronic pain scenarios. And then we still have to reconcile that with, we're dealing with other things like a trigger point and joint restriction and aberrant motor patterns, motor control, inadequate strength, tissue profiles, physiology. Like, we have to weigh all these and then determine, well, where is our access point? So the better you understand each aspect of what somebody is coming into you with, I think the better physician you are. So I hope you appreciate this research article. One more time, Myofascial Trigger Points, Then and Now, a Historical and Scientific Perspective by Shaw et al. Out of 2015. It's a good article. I'll obviously put a link to it in the show notes. Thanks, guys.